So as Steve said, the focus of this is really discussions regarding rectal cancer. And so we're going to try to work our way through it. And to start the process, we've asked Steve Hun from Washington University in St. Louis to talk to us about changing your approach to early rectal cancer. So Steve, let us know how we should change.
Thanks, Peter. And I want to thank Jim and Steve for inviting me here to talk today. I do not have any disclosures. I'm sorry I don't have a slide, but I have no disclosures related to this subject. And this is not a 10-minute subject, so please forgive me if I appear to gloss over things. This is probably a several-day symposium as a subject, so I'm going to move pretty quickly. I first just want to talk about breast cancer because about 15 to 20 years ago, the paradigm or the standard of care for breast cancer changed dramatically. In the 80s, if you had breast cancer, you got a mastectomy. That was the standard of care. A large trial, 1,800 patients, was undertaken in the late 70s, finished in the mid-80s, and by the mid-90s, everyone accepted that conservation therapy was just as good as radical surgery. And that's where I think we are 20 years later with rectal cancer. In the year 2000, the group at Minnesota introduced their results from conventional transanal excision of rectal cancers and compared them retrospectively to radical surgery for rectal cancer. This is their local recurrence rate with T1 tumors, and you can see that they had no recurrences with T1 cancers with radical surgery, and they had an 18% recurrence rate with local excision. T2 surgeries was even worse, a 6% recurrence rate with radical surgery, and for local excision, they had almost 50% of patients that recurred locally. If you pool all of the results, including Minnesota's updated results, the pooled results for T1 cancer local recurrence is about 20% and about 30% for T2 cancers. And that's not good enough. And if this was all there was to say, this talk would be over. But we've learned some things since that time. The first thing I think we've learned, and it started with the Japanese and a lot of retrospective reviews, is maybe we're not selecting the appropriate tumors for local excision. The group at the Mayo Clinic looked at 353 patients who had sessile adenocarcinomas and radical resections. These are T1 cancers, and they looked at some Japanese findings looking at the level of invasion of the submucosa, found that depending on the third of submucosa that's involved, these T1 cancers are quite different. Superficial submucosal invasion has a 3% rate of lymph node metastasis. Deep submucosal invasion has a 23% rate of lymph node metastasis, and this can be extrapolated to local recurrence for these patients, I think. The other thing they found was that the lower the cancer in the rectum, the higher the rate of lymph node metastases. So conventional transanal excision was mostly going after these lower third rectal cancers, the ones with the highest rate of lymph node metastasis, whereas the rectal cancers in the upper rectum have about an 8% rate of lymph node metastasis in their study. Their study also reinforced some of the other risk factors for recurrence, including poor differentiation, close margins, and lymphovascular invasion. So is it our technique? Is that the problem? We all know that local excision is not a very elegant technique. We don't have good visualization, and we oftentimes really beat up on the specimen. In the late 80s, Dr. Buse in Germany invented the system called the TEM, or transanal endoscopic microsurgery. It's a transanal approach to rectal cancer, which uses pneumorectum and magnified views to dissect tumors out endoscopically. This is just looking at, this is the group from Minnesota looking at their margins for transanal endoscopic microsurgery, TEM, versus conventional transanal excision. You can see that there's a significant difference in just the margin positive rate between TEM and transanal endoscopic surgery. This is 129 transanal cases and 42 TEM cases. A group in the Netherlands did the same thing. They looked at their margin negativity between TEM and transanal excision and found a significant difference favoring TEM. They looked at specimen fragmentation, again, significant difference favoring TEM, and these tumors were equivalent in size. They also looked at their recurrence rate, and these are for adenomas, not carcinomas, adenomas, and the recurrence rate for transanal excision was much worse than for TEM excision of these lesions. This is the group at University of Vermont. Again, specimen fragmentation significantly different between the two groups and margins significantly different between the two groups. So what if we do TEM approach to rectal cancer early stage? These are pooled data. These are all retrospective case series, but you see that our pooled data comes down from 20 and 30% recurrence rates down to 6 and 15% recurrence rates. So maybe TEM is better. The data supports that. We don't have any great randomized prospective trials that prove it, though. Is adjuvant therapy going to be helpful? In the late 90s and early part of this century, a lot of studies came out looking at mostly conventional transanal excision and adjuvant radiation therapy. If you pool those results, yeah, we're better than just plain local excision, but we're not perfect, and these aren't acceptable numbers for recurrence rates. This is a study out of Spain. This is a prospective protocol that they did. They took patients with T2 cancers. They took them all for a TEM excision, and then based on the pathology, they determined the rest of their treatment course. And low-risk T1 cancers, those without lymphovascular invasion, those with, that were well or moderately differentiated, were observed. They had a 7% recurrence rate. That's pretty good, and that's consistent with our other TEM literature. High-risk T1 cancers and T2 cancers received adjuvant radiation. Their recurrence rate was 11%. Better, but still not equivalent to radical surgery. So what if we had neoadjuvant therapy? Maybe with TEM, we're dropping tumor cells in that resection bed, and they're taking hold, and that's why we're having recurrences. This is Dr. Lazzocchi in Italy. This is one of the few prospective randomized study with TEM. He took 70 patients with ultrasound T2 cancers, lower rectum, smaller tumors. They all got neoadjuvant chemoradiation, and they were all followed extremely closely every 6 months with a minimum follow-up of 5 years. You can see here all of the tumors had equivalent responses to the neoadjuvant treatment. And what he found is that there was no difference in local recurrence. 2 patients recurred in the TEM group, 1 with a radical resection. Their distant recurrences were equivalent, and they were able to salvage one of these TEM failures for an equivalent disease-free survival at 5 years. So this study is probably not adequately powered, but again, it suggests that with appropriate neoadjuvant therapy and appropriate techniques that we may be able to treat rectal cancers with less than radical surgery. What happens if we fail? That's always been the point that people, I think, try to make us fear, is that salvage isn't very good after local excision. In the best hands, or in the best studies, it's around 60%. If you look at the Memorial Sloan Kettering data, it's 42% 5-year survival if you look at both local and distant recurrence. So that's not great. But remember, that's a small percentage of these patients. So I'm going to take a lot of liberties with this slide. These are mostly kind of extrapolations of data, but I put this slide up here because I want to make a point. If we just look at transanal excision versus radical surgery, there is no question that radical surgery is a better technique. How about TEM? We improve the technique. We improve our access to these perhaps more favorable tumors. We're going to improve our numbers a little bit. If we had neoadjuvant therapy, we're going to make our numbers even better. I didn't go into the neoadjuvant therapy for T1 cancers because that's a controversial issue, but for T2 cancers, we get a lot better with our cancer-specific survival. And then you add salvage into the mix, and you get about a 3% cancer-specific survival for T1s and a 4.5% for T2s. That's equivalent to radical surgery. So I think we need to perhaps rethink our standards for these patients. And I usually put this slide at the beginning, but I think it's important now that we see that we can at least come close with radical surgery. We can't just look at oncologic outcomes as the only thing that's important in treating these patients. There's a lot of morbidity from radical surgery of the rectum. It's got a low but real mortality rates. You've got bladder, sexual, and bowel dysfunction. Some patients require temporary stomas. Other patients need permanent stomas, and it's much more expensive than local therapy. So this is my main point. I know Tom Reed is going to hopefully reiterate this in his talk. The main thing is we need to get a large, multi-center, prospective randomized trial to look at these issues. You guys might say that there's been one done, and there was. The ACOSOG Z6041 trial looked at just that, T2 N0 clinical cancers. They got neoadjuvant chemoradiation, Xeloda, oxaliplatin, and 54 grays. They then went for some type of local excision. And the early data was just released this year in a publication in the Annals of Surgical Oncology. Complete pathologic response was present in 44% of patients. And I didn't get into that today either, but there's a lot of data, subset analyses, which will tell you that that is a marker for an excellent outcome with local excision if you look at patients that have complete pathologic response. The problem with this study, it was a fairly toxic regimen for the patients. So in summary, for early rectal cancer, if the oncologic outcome is the only consideration, yeah, radical surgery is probably better. But improvements in technique and neoadjuvant therapy improves our local results. I think it should be the standard of care for certain low-risk selected tumors. And I didn't get into this, but I also think it's going to come to bear that selected treatment based on the response to neoadjuvant therapy is warranted. And then I'm going to let Tom tell you how we need a trial. Thank you.